Hello, today I'm talking with Dr. Bruce Lanphear. Bruce is a professor of health sciences at Fraser University. He's a public health physician and a paediatric epidemiologist that specializes in environmental exposures, including lead and other toxic chemicals, including fluoride and chlorpyrifos. Dr. Lanphear has an MD from the University of Missouri and an M.P.H, a Master's in Public Health. He's served on the Lancet Commission on Pollution and Health. He's been an advisor to governments and he's served on many boards. His citations have doubled in the last 5 years, and your H index is 105 for the fussy people watching. And Bruce, you are the founder of Little Things Matter. It's an international team of scientists, researchers, physicians, graduate students, and public health practitioners and advocates. And you've produced an amazing Little Things Matter. Search for it. It's an amazing video on lead. And it shows the bell curve of IQ moving. So I'm just saying that at the start in case we don't say it again. So thank you very much for joining us today.
You're very welcome. Glad to be here.
Thank you. So I thought we'd start with the concept of the environment as an under-recognized driver of disease. Could you please talk about the public health revolution in the 18th and 19th centuries and what happened then, and the fact that we possibly are ready for another public health revolution around our contaminant burden?
Yeah. Well, what we really saw when you look over the past century in the United States and Europe, we saw this tremendous increase in life expectancy. And that happened not because old people lived longer, it happened because children stopped dying. And when you start to unravel why did children stop dying, very little of that reduction in mortality was because of medical care. And most of it even happened before antibiotics and vaccines, which is not in any way to diminish antibiotics and vaccines, but it's to say that there were a lot of population strategies. For example, better nutrition with like vitamin A, reducing the amount of soot in the air that then allowed people to have vitamin D and reduction in rickets. When you go back and you begin to look at why children stopped dying, it was because of population strategies. And I should say there was one vaccine in there, smallpox vaccine, that led to those reductions. And so one of the things we need to revisit is this idea of why did people stop dying? Why did children stop dying? And why did life expectancy increase? And when we really start to unpackage that, we begin to recognize that we are failing today in many ways to continue to use those population strategies. I can talk about that with lead. When I first started to get involved with lead research, the experts said the way to protect children is to tell the moms to wash their hands, to wash the children's hands, to do a better job cleaning your house. Well, we did randomized controlled trials and it didn't really make that big of a difference. But when lead was taken out of gasoline, blood lead levels plummeted, right? So the idea is you go to the source and you reduce the source of exposure. That's the population strategy, the type of population strategy we really want to use.
We think our genes play a major role in our health, but when the genome-wide association studies came out, that we found that actually they weren't such a big, didn't play such a big role. You can talk to the rising case of cancer in children. Could you talk about that, please?
Well, let's focus on genes for a minute. I mean, try to put them in perspective. Certainly for rare conditions like cystic fibrosis or Huntington's disease, uh, genes can play a big role, a dominant role. Not the whole thing, because even with cystic fibrosis, if you have cystic fibrosis, one of the many mutations, and you're exposed to tobacco smoke, well, that matters, right? So even with those uh, dominant genes, environmental exposures can make a difference. So for those rare conditions, genes play a real important role. When, for example, with autism, geneticists have tried to identify dominant genes, they came up short, at least when we talk about common risk factors for autism. Where there seems to be promise is first, environment seems to be more important in some ways, but when you really begin to find impacts or when you look at gene and environment interactions, the reason that's important is if you want to understand why conditions rise or decline, that's not going to be because of changes in our genes. That's going to largely be driven by environmental triggers, which might operate through genes, right, and shift our epigenetic patterns, but it's going to be driven by the environment. And so when we look at, for example, the fact that coronary heart disease used to be rare a century ago, and now it's the leading cause of death, we shouldn't be looking for genetic changes. When diabetes increased among the Pima or Odom Native Americans, we shouldn't be looking for genetics, although that's where most of the money seems to go early on until we throw up our hands and say, well, maybe it's not genetics. But we're really at a point where we should begin shifting it, right? So in the early part of this century, the first 10 years of the 21st century, over the NIH spent over $1 billion to understand the etiology of autism because it had been climbing up. Well, they spent 96% of that on genetics and only 4% on understanding the environmental triggers. And as you said, we came up short. We should be looking at both, but we really need to focus more on environment if we want to understand why autism has risen.
Yes, and you've got, you may have family histories too. So you've got not just perhaps a genetic, and you can have sort of mixtures of genes that might combine to, for example, make it difficult to absorb a certain nutrient that may in, alter or impact how your behavior is in the future. But you've also got familial habits, and as an epidemiologist, that must be very interesting to untangle those sorts of issues.
Well, at least to try, because it is challenging, it's complicated. And I think that, in a way that brings us right back to the idea of talking about toxic chemicals, because what happens is with very little research before chemicals are approved and put on the market, now we have to go back and find a way to disentangle whether this pesticide or that metal is causing something like autism or ADHD when there's all these other factors or characteristics. Now, that was probably a fine idea 100 years ago when the assumption was made that at low levels, these chemicals are safe or innocuous. But what we know today is that's completely false. That there's very little evidence to support that, whether you're talking about carcinogens or other toxic chemicals.
And you've recently researched a paper with Patty et al., the profiles and predictors of child neurodevelopmental and anthropometry,
Yes.
the maternal infant research on environmental chemical study. So you were looking at adiposity, and you were also looking at neurodevelopment and whether there was associations or not. Can you tell me about the outcome of that, please?
Right. Well, this was an attempt to try. I mean, the problem, the challenge of understanding these chemical cocktails that we each represent, right? Each of us is this different soup of these cocktails of chemicals, and many of them we know are toxic, and many we don't. But how do we make sense out of that? And so, what that paper was trying to do is to say if we can come up with profiles of adiposity and profiles of neurodevelopment, can we see patterns where those are associated with clusters of different chemicals? And in one way, I think it was a useful exercise. I don't think it got us as far along as we might have hoped. Um, but we're really still very early in our understanding of how do we make sense of these chemical cocktails. There are different statistical uh, uh, methods that can be used. None of them is perfect. Some of them, provide some clarification. But when it comes back to actual policy, in some ways, I'm still not convinced we found anything better than some of the old statistical methods. But that doesn't get us very far in terms of regulation.
Yeah, that makes absolute sense. And so just returning to that paper before we move on. So for people listening, neurodevelopmental success or not was more associated with lower household income, low birth weight, lower gestational age, decreased caregiving environment, greater maternal depressive symptoms. And the adiposity tended to lean with the higher pre-pregnancy body mass size. So
We really found some of the same kind of generic risk factors that predicted either adiposity or neurodevelopmental outcomes. They didn't really help us to refine maybe some of the chemicals. And that's really, what we're really trying to understand when we talk about this chemical cocktail.
And you've also done been part of a group, the Lau et al. Paper that looked at healthy adolescent microbiomes in a cohort study. So that's really interesting because we're starting to really tie the microbiome health with the neurodevelopmental, the mental health, and then we're starting to understand that mental health and micro microbial health is connected to uh, mitochondrial health. So there's some really interesting work going on. So that one found that socio-demographic variables were the most consistently associated with bacterial diversity and composition. How might
Yeah.
that tie in with if people are in a environment with, for example, lots of glyphosate being sprayed, for example?
Yeah. Well, we didn't look at that in that particular study. And a lot of these microbiome studies are really in their infancy. We're really trying to understand. I mean, I don't think anybody questions that our microbiome is valuable. How is it valuable? What determines the diversity and the health of a microbiome? How variable is the microbiome? I mean, one of the things that Hannah pointed out is that there was some sense that, by age 3, your microbiome was fixed. Well, that never quite made sense to me. And that's exactly what Hannah pointed out in that paper is that, if you want to um, look at a successful evolution of an organism, of humans, you're not going to fix something at one point in time and it's not going to be and it won't change ever, right? So that made sense. We're really still trying to figure that out. What I'd really like to see when we come to things like the microbiome is if we take something that we have a pretty good insight is going to alter the microbiome, let's say like arsenic. And could we, um, by random assignment, take 100 pregnant women and randomly assign half of them to get water filters that might reduce their arsenic intake by 50%? And this would be, of course, in a population where everybody's sort of getting the same amount of arsenic or similar amounts of arsenic from wells, but we try to reduce it in half of the women by random assignment. How does that change their intake of arsenic, the amount of arsenic in their urine, and then how does that change the microbiome? Now, in this case, we're actually able to control for something like arsenic, right? Because of that random assignment. And I think those kinds of studies could really help us better understand how these chemicals might impact the microbiome and microbiome diversity. And then ultimately, if we have studies that can follow children and families long enough, how does it impact overall health?
The challenge that I would see if you were undertaking such a study is that water filter would filter out more than arsenic.
It's a great point. That's right.
So it becomes, we start talking about a contaminant burden. We start talking about the problem that we have a load of all these different pesticides and chemicals and, you know, makeup and dietary ingredients and cleaners and solvents, and that becomes a burden. So if you're doing a study like that, that must be extraordinarily difficult to control for something like that.
All those different chemicals. Yes, absolutely. And I think in some ways, what it means is we'll never be able to completely isolate one chemical and its impact on human health unless we dose people with it, right? That's the idea of drug trials. I don't think we want to do that for potential environmental toxicants. Um, on the other hand, I think there's a lot to be said, particularly because we're concerned about these cocktails of chemicals we're exposed to. One of the things, for example, we've talked about over many years, but it would be expensive and have not found the funding for it. What if we were to randomly assign 10,000 pregnant women who are eating conventional diets? Half of them would get an organic diet. And then we'd look at nutritional parameters, we'd look at adiposity, we'd look at chemical burden in the children and the families. We'd follow them out and to look at differences in rates of asthma, obesity, learning problems, ADHD. Now that's probably going to be a 10, 20, $30 million study, maybe more. But it might give us some insight that we don't have. We won't be able to isolate the impact of chlorpyrifos from cadmium, for example, but maybe that's okay. Maybe what we really want to do is to say, how do we identify the optimal diet for families?
And this goes back to your comment before. So $1 billion could be put towards 96% of it was put towards studying genes for autism. And you're talking there about 20 to $30 billion to conduct a long-term trial that would look at basically the multi-morbid effect of whether a cleaner diet drove a wide variety of conditions. And you're in a unique position, Bruce, because you can talk about this. This is your life. Cohort studies, looking at toxicological exposures, looking at shifts in populations. Can you talk a little bit, for example, about the MIRAC, the Maternal Infant Research on Environmental Chemicals study?
Yeah, so the MIREC study is a pan Canadian cohort study of pregnant women and their children. It was started in 2008 to 2010. That's when the families were enrolled. They were from 10 cities across the country, and we have extensive measures of different types of chemicals from PFAS to pesticides, including glyphosate and organophosphate pesticides and pyrethroids and metals. And we've got not only those biomarkers in the blood and urine, but also in breast milk. And then we've been following the kids now since then, and we've gone through different cycles. One of the earliest cycles that I helped design was on neurobehavioral outcomes when the kids were 3 and 4. And then the second cycle was around endocrine disrupting chemicals and obesity. And that continues. So it really was a uh, powerful way to try to get on top of how chemicals impact children.
And so in the biomonitoring that you've done, it's been urine, it's been through breast milk. Have you taken blood serum as well?
Yes. Serum or plasma and whole blood as well. And that's been one of when you look at cohorts around the world, one of the things we wanted to do is replicate what we'd found with metals and coronary heart disease. We're finding that lead and others have found that arsenic and cadmium are some of the most potent predictors of coronary heart disease, which is the leading cause of death worldwide. But many cohort studies don't collect whole blood. And so that's been kind of a challenge. I mean, we have enough to say to draw conclusions about these metals and coronary heart disease. And there's some really interesting new data showing that lead and cadmium, for example, might create these little tears in the endothelial cells lining the arteries in the heart, for example. And that could indicate that metals are creating the first lesion that leads to atherosclerosis. We still don't really know what initiates atherosclerosis, but this is, I think, at least what I've seen, the most promising clue to what initiates the leading cause of deaths around the world, both in low to middle income countries and in more affluent countries.
And anecdotally, in 1925,
In 1925, so you're referring to the U.S. Surgeon General's meeting that brought together scientists from Yale and Harvard and other universities and industry representatives to ask a very simple question. Is it safe to add lead, it's called tetraethyl lead, to gasoline? And the scientists said, don't do it. Pretty consistently. One of them, Yandel Henderson, said if you do it, it's going to cause a scourge worse than tuberculosis, which was the leading cause of death at the time, with slow lead poisoning and hardening of the arteries. On the other side, Robert Kehoe argued that even if we knew lead was a poison, until you'd proven that it was a poison when added to gasoline, government had no right to prohibit them from using it. Now that seems, when I put it in that perspective and what we know about lead, it seems like a terrible, terrible idea. And of course, we should have learned by now that we shouldn't do that. But that same basic principle, the Kehoe Rule, is still how we regulate chemicals today.
yes. And just as a note, in New Zealand, we still have lead in jet fuel, and there are still lead in some fuels used in infrastructure works. I'm aware that, so we can't pretend that lead isn't.
That's right. And I mean, lead production has never been greater when you look at it around the world. The largest uses for lead acid batteries, but smelting of those or secondary recycling of those batteries is still a major source. Lead glazed pottery, adding lead to spices, either to color them or to make it weigh a bit more, adulterating spices makeup. I mean, it's still unbelievably prevalent, and 1 out of 3 children are estimated to have lead poisoning around the world. 1 out of 3 children. It's really quite striking, and we're just beginning to try to tackle this as an international community.
Yeah, and the Centre for Public Health Research in New Zealand, our children do in New Zealand do have lead levels. They have much lower lead levels now than they used to, but they still have lead levels of lead in their blood, and adults have more. Just moving on now, I would love us to talk about sublethal and non-monotonic, non-linear effects from environmental chemicals. Now, in medicine, hormone level drugs that exert a greater effect at a low dose level, at parts per billion, parts per trillion, are not controversial. Yet they seem to be controversial every time doctors and epidemiologists want to talk about environmental chemicals causing greater harm at a low level. Can you flesh this out a bit, Bruce, and help people understand this kind of crazy phenomenon?
Yeah. Well, let me do it with lead. And lead has some endocrine disrupting properties, but not all of its properties are via the endocrine system. I first saw this about 20 years ago, and the first time I saw it, it actually went right over my head because I was trained to think that chemicals at low levels or metals at low levels were innocuous or safe. I was also taught to think that either there's a threshold that is no effect until you get to a certain concentration, or for carcinogens that there's a linear no threshold model. So I really operated almost from the standpoint of that there's going to be linear relationships. So it's a very simplistic way of thinking about it. Well, the first time I saw it, it went over my head. The second time I saw it, we were looking at what happens as blood lead levels increase in a group of children. And we saw that beginning at the lowest measurable levels, there was a steep decrement. And then at higher levels, it was attenuated or decelerated. So the first 10 microgram per deciliter an increase in blood lead was associated with about a 6 to 7 IQ point drop. The second 10 microgram per deciliter increase was about a 2 to 2.5 IQ point drop. And the third was about a 1 IQ point drop. So proportionately, we saw greater harms at the lowest levels. Now, if you flip that around, that's called the decelerating dose response relationship. If we shift that around, we can see the same pattern with something like airborne particles, PM 2.5, and death from cardiovascular disease. But now here, we've kind of flipped it, and it's almost the mirror image. At low levels, we see immediately a steep increase in the risk of dying prematurely from heart disease. And then at higher levels, it decelerates or flattens out. So now that has been seen for lead and IQ deficits, lead and cardiovascular disease mortality. Again, at higher levels, it increases sharply and then decelerates. PM 2.5 and mortality, benzene and leukemia, and asbestos and mesothelioma. Now, one of the things that those have in common is they are the most well-studied and widely disseminated toxic chemicals out there, right? I've not found any evidence in human studies for a threshold. Well, maybe with one exception, and that's mercury in fish. And it's not definitive, but you do see some evidence, and it may be simply because most of the methylmercury we ingest is in fish, and
And
fish is beneficial.
and so a threshold is the lowest safe dose you can have for a lifetime.
That's the idea. That's correct.
Yeah.
And so with something like mercury in fish, it may be that there's no threshold, but because there are benefits to ingesting the vehicle, in this case, thinking of mercury as the major agent, it may mask any threshold. So the idea that there are thresholds and the whole idea of hormesis as maybe these chemicals are beneficial at low levels, I've not seen any evidence in human studies for that.
No. And and I think was it Professor Philippe Grandjean talked about the fact that he is suspects perhaps that environmentally relevant levels of fluoride in the environment, we have grown the capacity to tolerate that, but it doesn't mean it's beneficial. As well, if we were living on the diets that our grandparents and grandparents had with consumed with lots of fiber, for example, we would be moving those heavy metals or whatever they were through our system so much more quickly. And so we wouldn't have probably prolonged exposures in the dietary tract, perhaps. So there's all these sort of things that you can think about. Yes, it could be at an environmentally relevant level, but that doesn't mean that today in an urban population we could even tolerate that level right now.
Well, and you have to stop and ask, what is an environmentally, what is the background levels to something like lead and mercury? And one of my favorite slides that I was introduced to by Thomas Clarkson, who's international mercury expert, this was now 30 years ago. He had this slide that showed on a log scale that the essential elements like sodium and calcium were in the primordial oceans where our single cell ancestors evolved at very high concentrations. Lead and mercury, on the other hand, were there in very minuscule concentrations. And so we never developed the mechanisms to tolerate them or the physiologic need for them because they weren't really there in high enough concentrations. So even though you might think, well, lead and mercury, they're elemental. They've been with us all along. Yes, that's true, but not at the concentrations that we've seen over the past 200 or 300 years during the industrial, or even longer in some cases, um, during industrialization or during the Roman era where they were starting to refine metals and smelt metals. And so it's possible that having more fiber in the diet would reduce some of those exposures, but we're exposed to levels, well, 30 years ago, it was levels about 6,000 times higher than our pre-industrial ancestors. And even today, for lead, 10 to 100 times higher than our pre-industrial ancestors.
Pretty astonishing. Could you please talk a little bit about, for example, what a chemical class might mean and what additive effects from a chemical class might mean, but then also talk about what synergistic effects might mean, please.
Right. Well, this is something Rachel Carson talked about synergistic effects of OP pesticides in Silent Spring. Um, I've not seen evidence of that in humans, but we certainly have a number of examples of synergistic effects. And in fact, tobacco seems to be what one of my students called the great synergizer. It seems to interact synergistically with several things. So if you think back on the century-long epidemic of lung cancer, we mostly blame tobacco for that. And it does appear to be the major reason for the century-long epidemic of lung cancer, but it wasn't the only risk factor. So, for example, Pershagen found that both for arsenic and radon, if you're exposed to tobacco smoke and arsenic or radon simultaneously, the increased risk isn't just 10, tenfold for tobacco and twofold for arsenic, it's 25-fold if you're exposed to both. And so that's the idea of this synergistic effect. When you have two toxic chemicals uh, and you're exposed to both, you might think in some cases it is additive, but in other cases it's multiplicative and it has a big impact on the risk. And there are undoubtedly, even though we have some good examples, for lung cancer, tobacco plus asbestos, tobacco plus radon, tobacco plus arsenic. For lead and tobacco, we see that they act synergistically and increase the risk of children developing ADHD. But there are undoubtedly lots of different examples that we haven't even begun to understand in this cocktail of chemicals that we're constantly bathed in.
Yes, and in a previous interview, you talked about children with leukemia and the percentage of leukemia that's environmentally driven and the known causes of childhood leukemia. Could you just talk about that? Because that can show that kind of cumulative pressure on why children might become ill much more earlier than.
Yeah. I don't know that any of those are synergistic, but there's a group out of the University of California, San Francisco, that's been doing work on childhood leukemia for now over 20 years. And what they found is that a variety of in utero environmental exposures to either pesticides, um, highway traffic, tobacco exposure from the father, paints and solvents, and pesticides all contribute to an increased risk in childhood leukemia. And they estimated that about 1 in 4 cases could be attributed back to one or more of those environmental exposures. Now, there's been other things as well. Since then, benzene appears to be a risk factor, as does proximity to fracking and oil development. Now, could that be in part benzene? Yes. So there may be some overlap. But those appear to be important risk factors for childhood leukemia. The interesting, or maybe the troubling thing for me anyway, is that we continue to put most of our research dollars into identifying ways to treat childhood leukemia and too little to try to understand more about ways to prevent childhood leukemia. Now, I've asked pediatricians, it was a hand raising survey at 10 different um, meetings around North America, uh, including New York University and University of Madison, Wisconsin, the Canadian Pediatric Society. And I asked them the same question. How many of them would vote to increase funding to enhance the cure for childhood leukemia, which is arguably the poster child for finding a cure for cancer? And how many of them would increase funding to find ways to prevent childhood leukemia? That was very consistent across all 10 locations. What percent of pediatricians do you think voted to increase funding to enhance the cure for childhood leukemia?
I couldn't know because I didn't hear this story before.
All right. Well, only five pediatricians out of about 1,000 in the audiences voted to increase funding to enhance the cure, right? Almost all of them voted for more money to prevent childhood leukemia. Now, maybe that sounds like a surprise to some people, but treatment for childhood leukemia is daunting. It takes over families' lives for years. Uh, Other children are sort of neglected, right? And because there's so much need to focus on this one child. The cost, of course, is enormous. And so it really isn't a surprise. And I actually expect, nobody's asked parents this that I know of. I expect that parents would say something very similar, unless, of course, they had a child with leukemia. And then, understandably, they'd want more focus on treatment. Well, for those parents, we should ask a different question to be fair to them. Do they wish we had spent more on finding ways to prevent leukemia 20 years ago? And my guess is almost universally, we would put more money towards prevention. But if you look at where the National Cancer Institute in the United States puts most of its money, over 95% is on treatment, less than 4% for childhood cancer is on prevention. I don't understand that, and I don't think if people were asked that they would understand it either.
Yeah. Well, I understand that. I watched two parents die of two different forms of cancer in my 20s. One very short, one took 10 years to die, and I do not fund any breast cancer operative that is funding more treatment. I've stopped. I will support local care facilities, but I will not support that game of more medicine and more drugs for higher rates of cancer.
Well, one of the things, and they are complementary, right? The idea of clinical strategies and population strategies, and those are terms that Jeffrey Rose talks about. And if you're interested in prevention, Jeffrey Rose is a must read, Strategy for Preventive Medicine.
Yeah.
And he makes the point, and I think he's right, that we need to have those investments in clinical
Yes.
research, but
Yes.
we absolutely need, and we've been ignoring those prevention-oriented strategies. And so I think in some days I would say exactly the same thing you've just said, but it's really because there's been such an imbalance for so long.
There's a
Uh,
gross asymmetry. So I do not do that because I know how much money is going to drug development. It's not because I'm immoral or unethical. But if
right.
someone were to come up with an institute that where scientists had the freedom, and this is, we do not actually have any scientific freedom to research anything that is not innovative. So we do not have the scientific freedom for long-term funding in New Zealand to look at environmental chemicals. And so there's a reason there's not a professor with expertise in fluoride or glyphosate, um, no scientific cohort looking at phthalates and bisphenol A, because that's not what the government policy has erected. That the policy is for innovation for economic growth, and
Yeah.
that's just it's a captured in. So just going back, and people have heard me talk about this, but 15 years ago, secondary legislation, they put the entire Ministry of Science inside the Ministry for Business, Innovation and Employment. Completely caught it, captured it. So moving on, and
Yes.
so we're moving on to regulatory agencies. So one of the ways I would love to start talking about this is talking about in New Zealand, we see a re-evaluation for pesticides. A class of pesticides will be re-evaluated, and then they'll usually increase the authorization for it, and then they'll bring in a little bit of new industry science, and then that's fine. But we are not seeing that class. Let's say, for example, the triazine class, which includes atrazine and metsulfuron methyl. You will have other examples where that cumulative exposures, one on top of the other. So I get a little bit of atrazine and I get a little bit of metsulfuron methyl in my diet or my exposures. And why aren't we seeing class-based regulation to look at the total exposures?
Well, I think it's inconvenient. I think it's challenging. I mean, we're still, I would say that we are still struggling to evaluate one chemical at a time. right? I mean, we don't even do a good job with that. If you go back and look at chlorpyrifos, for example, uh, that was based, the approval of chlorpyrifos was based on a single study, and they used the wrong statistical analysis. Leanne Shepard has said if they had used the correct one, it may not have even been approved. Now, what I find so striking is that now let's go back and look at something like chlorpyrifos or glyphosate, which had two studies that it was based on, its approval was based on. So now what happens, the way our regulatory system is set up, is now that these have a golden seal of approval. It takes dozens and dozens, if not hundreds and hundreds, of laboratory studies, many of which might show it's toxic, and dozens and dozens, and maybe hundreds and hundreds of human studies that uh, primarily show it's toxic before you're going to overturn those very small, very inadequate approval studies. The system is set up to make it easier for industry to use chemicals. It's not set up primarily to protect our health. And at some point, maybe it's going to require a crisis like the thalidomide crisis. The problem, of course, is we're seeing that right now. We're seeing
Yes.
1 in 5 deaths around the world can be attributed back to pollution and toxic chemicals. But because these are slow moving epidemics, right? It's not like COVID or measles. We don't see them. They come across so slowly that we begin to think that they're inevitable, even normal. But things like lung cancer, coronary heart disease, both the leading causes of death around the world, those used to be rare. But now they're so common, we accept them as inevitable. The
Yeah.
price of living longer, which is absolutely not true. The story has been uh, uh, woven for us, and too many of us have accepted that story.
Yes. And we're also seeing, so what Bruce and I are talking about, and what we really want listeners to understand, is that these locked in studies where you get one or two really old studies, they will set the daily dose, which becomes the ADI. The ADI will be very, very high. And our daily dose, based on it being sprayed on food or in the environment, is disproportionately low. So they can basically do whatever they want. Now, this locking the old data in, for example, there's a 1981 Monsanto study that still today sets the WHO drinking water levels. And that's used by New Zealand and referred to. So we see that for glyphosate. We see that for chlorpyrifos. We see that for. Are we seeing that for phthalates and bisphenol A? Are you seeing that locking in of old data?
Typically, it happens, right? I mean, it's going to be once you've got something set, it takes years or decades to convert it or change it. Now, there are occasionally things like the Food uh, Pesticide Act in the 1990s that began to shift it more quickly, where there was a safety factor built in. That's in the United States. So there are occasionally things like that, or where there's a big shift. But generally, these things take years. And in some ways, it's not a surprise, but I think what it points to is a failure of the way we think about science. So let's say um, that fluoride 50 years ago was shown to be protective against tooth decay. And that sort of now becomes the dominant narrative that we operate out of. Well, over the past 20 years, people have begun to ask different types of questions. For example, nobody ever looked at whether fluoride was toxic to the developing brain 100 years ago. Now we have over the past 20 years, and we're finding a lot of consistent evidence that it's neurotoxic. Just last year, some experts out of the UK updated the Cochrane Review and asked the question, do studies that have been done since 1975 show that fluoridation, adding fluoride to water, protects against tooth decay. And they said, well, not in these studies. And so we've got new evidence. Science is not adhering to past stories. Science is evolving, is watching what's evolving as new studies come in. And we aren't that nimble at changing. And we don't want government to be so nimble we don't know how to, well, like the US government right now, right? It's so uncertain. We don't know what to count on. We need government to be solid, but we need it to be able to react much more quickly than it has been to new evidence. Maybe a year or two, not 15 or 20.
Yes, and part of that I think is they've kept the scientific literature at arm's length. So the regulatory agencies lock in very tight guidelines that require a certain subset of studies to be supplied. And for example, with the WHO and the Food and Agricultural Organization, they meet with industry every year or every few years, and the new guidelines usually won't come out without industry having confirmed that that is reasonable and industry approve. So if we were to look at Bruce's work, looking at urine levels and the biomonitoring data with blood levels and where that risk is starting in New Zealand, that epidemiological data is not being looked at by the regulators as evidence for harm. So they're just, so we can see really narrow use of guidelines, and they keep saying, well, there's a little bit of new information in the literature, but we've still got the guideline data, and just this the barriers that get formed around the regulatory agencies where they really don't have to look at that weight of evidence is, I think it's a massive corruption of regulatory agencies. And the other game they play is, oh well, we can look at this other regulatory agency for advice. But that regulatory agency has the same guidelines, which is focusing on the industry data and locking in that old study. Now you've got, and when scientists go to these regulatory agencies and say, we can think differently, we can think more broadly, they can become locked in and they can become sort of choked themselves. So can you tell us about the terms of reference experience that you went through, please?
Yeah. Yeah. And maybe just before I do that, I think to point out that I think what you're talking about, the dynamic you're talking about, is that there's a tendency for regulatory agencies to like to be able to have simple, clean answers to deal with. And laboratory studies are often simpler to deal with than epidemiologic studies. And so there's a tendency to sort of dismiss the epi studies. So a couple of years ago, I was nominated to serve on the Health Canada's Pest Management Regulatory Agency, or PMRA. And during our first pre-meeting, we were invited to review the terms of reference. And the terms of reference basically said that we could answer questions asked of us, but we could not ask questions. Now, the goals of this independent scientific advisory committee that they were putting together was to increase transparency of how pesticides were regulated, and to provide confidence that Canadians were being protected against pesticides. So as soon as I saw this terms of reference, that we could only answer questions, not ask them, I immediately said, I can't serve on this committee. I certainly can't serve as a co-chair because I can't help you be transparent, and I can't help you be confident that you're protecting Canadians if I can't ask questions. So there was a bit back and forth for that next month. And then one of the leaders of PMRA said, look, if we tell you that we'll change these terms of reference and that we're comfortable, we're confident you'll be comfortable with them, would you agree to serve as the co-chair for a year? And I said yes. Well, so we did for the next year, and there were several, let's say, challenges. For example, in the middle of the fall, we found out that from our MyREX study that about 70 to 80% of pregnant women were regularly exposed to glyphosate. Now, this was new evidence. They didn't have this back when they had set the allowable levels. And so I said, well, how do you incorporate that into risk management? Now, during this time, they were trying to shift from an every 15-year review to what they called a continuous review. But when they said continuous, it just meant they were going to do it every 7 years. So it really wasn't continuous. It was just a euphemism to say, we're going to try to do better, which is nice, but it wasn't continuous. I never could get an answer about how this new study was going to be incorporated into the risk assessment process. Um, they wanted us to evaluate how they approve pesticides. We thought that was a great idea. And I said, well, let's look at something like chlorpyrifos, which was being phased out in Canada, or glyphosate, where maybe there's some human data we could learn from. We weren't allowed to use that. Nor would they answer the question when I pushed 4 or 5 times, why aren't we using some of these pesticides so we can actually learn how the approval process and the reapproval process happens? So anyway, those are two typical examples. About 9 months after I agreed to serve as co-chair, I was sent the revised terms of reference. And there was maybe 2 or 3 words changed. Basically, when I asked for clarification on what that meant, it meant that I could ask a question, or at least I could submit a question. And within 3 or 4 months, they would get back to me to let me know if it was an acceptable question. And then we would have a discussion at the next meeting. So it really hadn't changed much. Now, at the same time, we were serving on this science advisory board. It was scientists. None of us had a conflict of interest. There was also a scientific advisory council that included representatives from industry, and their terms of reference was much broader. So I was really struck by this and said, look, number one, I don't want to sit on this committee and give people the impression that I am confident that you're protecting Canadians. I'm not. Nor do I want to serve on this council that has less of a mandate than the advisory council that has industry representatives on it. I think that's completely inappropriate to have people with a conflict of interest, a financial conflict of interest, serving on this advisory council. So I ended up stepping off of that, resigning, and writing up a several-page letter. Most of the rest of, I think all of the rest of the scientists on that committee stayed, and I think that's absolutely right. That's, what they felt like they could make a difference. I'm still confident that I made the right decision. There was a lot of discussion about it, a lot of media attention, and I think it's important that people know what the challenges are when we try to regulate pesticides and other chemicals, and they know what the limitations of those regulatory agencies are.
I think that's a really important point. And I've got an interview with Professor Philippe Grandjean where he talks about his experience with the FAO and WHO when he was trying to get tighter, better data in, and that couldn't happen. And he left, and then I think they left his name on the list. And so what that happens is people like you and he, they can use that as a sort of a green lighting, greenwashing, a tacit approval that we're doing a great job because look at who's on our committees. And so what I've seen in New Zealand, I now run, and I please people listening to this, do Official Information Act requests to understand the terms of reference for people that are on these boards, that are chairing these committees, to find out if they are limited in what they can do. Would you be able to possibly please talk about the lack or the failure to place at a high level of importance the impact of endocrine disrupting chemicals and neurodevelopmental toxicity, showing whether there's EDC, hormone disrupting effects, there's neurodevelopmental toxicity, which can be crossover or be disparate. Um, we're not seeing that at a high level in the regulatory agencies yet. They're not valued.
Yeah. Well, this is a bit outside of my expertise. I certainly study endocrine disrupting chemicals in the cohorts that I'm involved with in terms of regulatory testing. That kind of gets beyond my area of
Yeah,
expertise.
no,
So I'll leave that aside.
yeah. So just as a simple example, in the rodent trials for glyphosate that are locked in and very, very old, they look at reproductive toxicity, so look at next generation effects, and they also look at developmental toxicity. But the reproductive toxicity really focuses on whether they have the tremors and malformations. So in these trials, there's absolutely no consideration of neurodevelopmental toxicity, which I find is crazy. Could you and as and not, so we're talking about the regulatory agencies, we're talking about terms of reference. There's an example too. You were talking about the National Children's Study in the US. What that was shut down. Please, can you explain that story?
Yeah. Yeah. So the National Children's Study, the act was passed under President Bill Clinton in the late 1990s and was started to be put in place in the early 2000s. And I was involved in some of the early discussions and then was the co-PI in one of the Vanguard sites. There were 7 Vanguard sites around the country. And there was a lot of, I would say, discussion about what's the best way to establish this type of cohort. At one point, we were talking about 100,000 families and their children, one child. And I think we could have certainly justified that based upon wanting to be able to answer lots of questions about the environment. And that really was the key part of it, was understanding environmental triggers, including things like pesticides or metals. There were a number of things that began to happen in the early 2000s. One is there was pressure from the chemical industry, and there was an attempt by some of the federal officials to try to not emphasize the environmental chemicals so as to not create this tension, right? So not to get the chemical industry all fired up and to sort of be left alone. So that was going on. And then in comes Francis Collins, and Collins really wanted to do this large scale genetic study. And that was his goal. And he, in part, he needed to do something to keep money flowing. Where they're starting to see the end of the tunnel when it came to decoding the human genome. So what's next? So he wanted to do a large cohort study, and he had different names for it at different times. And I remember a meeting with, there were just 2 or 3 of us university types, and then the rest were NIH researchers and administrators. And, we were at that point, very willing to say, yes, why don't we take advantage of this National Children's Study? If you wanted to do a 500,000 person gene environment study in families, well, why wouldn't we use these children sort of as, and the parents as the beginning? And then if we bring in the grandparents, well, we could almost have 500,000 within a decade or so. So that was promising, but then he said something at the very end that just really stuck with me. He said, I'll do nothing in any way to jeopardize the National Children's Study. And I was left with, why did he feel the need to say that? But it became very clear that he was really interested in the genetic part of the study. And over the next 8 to 10 years, they gradually were whittling that down, coming up with reasons to defund it. And then I think it was around 2010, they finally terminated the study. And it was, I think, a tremendous loss to understand environmental influences, not just pesticides and metals, but the environment in its broadest dimensions, where we could begin to understand what are some of the root causes of the chronic diseases and disabilities that are impacting children. And by following the parents, we could have understood some of the leading risk factors for chronic disease in the parents and adults. It was a tremendous loss. It was almost criminal in what we lost.
And you had recruited people and they'd started, or were you still in the study design phase?
No, we had started to recruit families in many of the Vanguard sites.
And how much was invested before the shutdown?
Oh, I don't remember. A lot.
Yeah, I think you might have mentioned 1.3 billion.
It probably was. And it was going to cost more than the original predictions. For sure, that was one of the challenges. But, it would have been, if you look at, if you compare prevention versus treatment, invariably prevention, maybe not 100%, but the vast majority of the time is going to be less expensive. And so we had this tremendous opportunity not only to reduce disease and disability and death, to understand root causes of many of the chronic diseases, but also in the long term to reduce suffering and save money. It was a tremendous opportunity. It did morph into different cohorts called the echo cohorts. Those are going to be valuable, but it's still not going to be the same kind of wealth of information that we could have garnered from the National Children's Study. So it was a real loss.
Yeah. So New Zealand had a much smaller institute called Gravida that was set up for very similar reasons. It may have been set up at the same time with the same, energy, political energies, but it was then shut down. And we've got a Centre for Public Health Research that limps along, amazing scientists, but on a tiny budget. People don't know about it. They don't have money for white papers and presentations. And that's all. It's quite alarming. And what I'd like to talk about, because with that study and with suffering, the issue of multimorbidity. So we had a paper come out in New Zealand. They looked at the cost of one illness, a second illness. And once you get more, the cost of multimorbidity is multiscalar. So the example, of course, that most people know about is metabolic syndrome. And you're looking at the drivers from toxic chemicals. So are you aware that if children are exposed to particulate matter, to lead, to glyphosate, that they don't end up just with one illness, they can end up with multiple illness presentations?
Yeah, yeah. We rarely expect a chemical anymore to just result in one problem. They typically result, and I can't actually think of anything where it's just one problem. Now, if it's a new chemical, we haven't studied it very well, sure. And so I think we should expect that. But I think in some ways, even more important than one chemical having multiple different endpoints, health endpoints, is recognizing that there are some communities who are much more heavily exposed to a variety of toxic chemicals. So, for example, when I lived and did studies in Cincinnati, Ohio, over the Rhine was a neighborhood where children lived in older, poorly maintained housing with higher amounts of lead. Cockroaches were also a problem, and in many cases, they might have monthly applications of pesticides. They were right in the downtown district with highways surrounding them, oftentimes living in multi-unit dwellings with secondhand smoke. And so, on top of all of that, now you may also have heavily processed foods, which are going to contain more plastics. And any of these things, we talk about air pollution or plastics as though it's one thing, but of course it's not. Secondhand smoke is thousands of chemicals. Air pollution is composed of thousands of chemicals and metals and gases. Plastics have many different additives, from bisphenol A to phthalates to lead, right? And PFAS and PBDEs and all of these other things. And then, of course, if you have older furniture, it's going to be chemical flame. So we tend to see some of these toxic chemicals concentrate in those communities where we also see more chronic conditions, more learning problems. And so, in many ways, it's not so much that one chemical can cause many things, although it can and often does, but it's this concentration in impoverished communities where we can really see a lot of the chronic conditions arise.
Just as it's a small example, and I'm going back to a single chemical, but I really wanted to bring this up because you recently did a study on fluoride and iodine.
Yes. So we'd already done several studies showing that fluoride, whether it was in water or measured in the urine of pregnant women, was associated with diminished IQ in their offspring, in their children. Now, when we looked at in our Canadian cohort, which is not typical of the other cohorts, but in our Canadian cohort, when we measured fluoride in the mother's urine, we primarily saw IQ deficits in the boys. And we could even see more, a stronger relationship with performance type IQ scores, not verbal scores in boys. And so then we began to ask other questions. And one of those was recognizing that fluoride uh, competes with iodine into the thyroid gland. Would we see something if we looked at pregnant women who had lower iodine versus sufficient iodine as an interaction or modifying fluoride exposure? And when we looked at that, we found that the boys whose mother had higher fluoride and lower iodine did the most poorly on their uh, IQ tests. We still saw some decrements in IQ in the boys whose mothers had sufficient iodine, but it was when you had both of them. Now, it didn't look synergistic, it looked additive, but it was still a much larger decrement.
So that's really interesting. So when I add the discussion you've just had about low income communities in polluted environments with lots of drivers that can lead to poor health that are environmental. One of the big arguments put forward in our local region in Tauranga here for fluoride in drinking water was to support Maori, to support low income communities because they weren't cleaning their teeth. So of course that was outside the language that we were able to have. And all I could think of was that these guys have so many neurodevelopmental challenges from the absence of nutrition, from the world around them, that then they were going to add fluoride on top of that, thinking that it was going to be a benefit, but there was no language for looking at the neurodevelopmental toxicity. And there was this is so people are trying to be moral and ethical. So they're trying to be good people, but because we don't do this other research to bring up these other issues that are actually fundamentally social and political, we're not able to really, people haven't heard of it before, so they can't process it. And I don't mean that in a patronizing way. I mean that the
Yeah,
media's not covering this. It's really hard to get traction on this.
right.
Would you say that all we see is opportunity, opportunity, opportunity? There's so much we can do.
Well, let me talk a little bit about some of the nutrients and toxicant interactions,
Oh,
because
I'd
I
love
think
to.
that's really at sort of the forefront of much of the work that's being done right now. You look at autism, for example, there's been some really fascinating work showing that if you're exposed to pesticides, that can be a risk factor for the development of autism. But if you're exposed to those pesticides and your mother has insufficient folate or didn't take folate during the multivitamin during pregnancy, that those children are at even greater risk. We saw some evidence of that in our Canadian birth cohort with phthalates and lower folate. There's some evidence of that with lead and folate. We also know that absorption of some of the toxic chemicals can be uh, reduced if you have, for example, adequate calcium intake, or if your iron status is sufficient, you may not absorb as much lead. And so, more and more, we need to understand how nutrients interact with toxic chemicals, very much in the same way that we saw them interact with infectious disease, right? So, like with measles, children who are vitamin A deficient and infected with measles are at much higher risk of developing pneumonia and dying. And so we're seeing that same kind of pattern that was seen with infectious disease now with toxic chemicals,
Yes.
whether it's about absorption or whether it's about the health effects.
The WHO says high dose vitamin A is a first line treatment. There is no policy paper in New Zealand talking about vitamin A in measles. And we have very high risk in, for example, Maori and Pacifica populations that have low level nutrient. Moving back to the folate issue, we're learning more and more about gene variants. So you've got MTHFR. So imagine an MTHFR person with that gene variant that struggles to process folate. They've got low folate and they've got greater exposures.
That's right. Yeah, and we're just, as you can begin to see, we're struggling now with the same thing we're struggling with chemical cocktails. If we want to understand how genes interact with insufficient folate in the diet or inadequate supplementation and chemicals, now a cohort of 2,000 children and pregnant women may not be enough. Now we need that 100,000 person
Scale.
national study that no longer exists, right? And so it becomes really challenging to tease that apart, but those can be really important interactions to study.
Could you talk about, because we haven't actually talked about this yet, and we are getting to the end of our interview, what DOHAD means and windows of vulnerability, please?
Yeah, so you're talking about developmental origins of health and disease. Um, that was a concept. I mean, it's been around a long time, but it really was kind of popularized by David Barker. And the idea is that what happens to us at the earliest stages of development can have long-lasting impacts. And you can think about that in a very simple way. For example, if you look at how children's brains develop and their cognitive abilities develop, they sort of increase, increase over the first 10, 20 years of life. And then, maybe a little bit into the 20s, and then they sort of plateau. And then as we get older, up into the 50s and 60s, then we start to see cognitive decline. And if you're exposed to higher amounts of a toxic chemical like lead, you may never reach the same peak cognitive ability as somebody with lower exposure. And then on the other end of the spectrum, you may have accelerated cognitive decline and meet the threshold for dementia sooner. Now, you can see the same thing with bone health or respiratory health, that if you have exposures that restrict the growth of the pulmonary tree or restrict the bone from becoming as healthy and dense as it might otherwise be during adolescence and young adulthood, then at the other end of the spectrum, you're going to reach that threshold for osteoporosis or restricted lung disease or chronic obstructive pulmonary disease earlier in life. So that's the basic idea. And what that means, of course, is we need to be thinking about the health, our health, at the earliest stages, even before conception.
Yes,
So if we
absolutely.
really value health, we need to think a lot more about children, but not surprisingly, most of our resources going to take care of people once they're already sick, and that tends to be when they're older. So we're putting very little of our investment in that early stage of development.
And could you talk about windows of vulnerability, particularly the blood-brain barrier, please?
Yes. So the earliest that I'm aware of this idea of windows of vulnerability was identified when thalidomide was prescribed to pregnant women. If Thalidomide was ingested as a drug from the 27th day to the 40th day after conception. That's when the limbs were developing. You are at increased risk to develop phocomelia or seal limb, where the limbs don't fully develop. So that very narrow window really gave us this idea, this concept that exposures that happen during different stages of development can be especially important. So you might find, for example, maybe you measure a chemical, and I'm just going to use a hypothetical like air pollution during the first trimester of development, and you don't see any increased risk for autism. But if you had measured it in the third trimester, you might. And so understanding the windows of development is important if you want to understand when we're most vulnerable and when we have to measure an exposure. Now, at this point, you sort of have to do it through all three uh, trimesters, for example, and even into childhood, because we don't understand a lot about those windows. We have good examples, but we don't understand windows of vulnerability for most of the chemical exposures we experience.
Can you tell me why babies consume more by body weight than their parents, and that hence they are likely to be exposed to more contaminants than their parents?
Yes. So the basic idea is that children are growing so rapidly that pound for pound, they need to ingest more, breathe more. Their metabolism is quite high. That's one of the reasons that they have a higher body burden of many chemicals like lead, like PBDEs, that flame retardant that doesn't work very well and now has been restricted in many parts of the world. Um, Even tobacco metabolites and pesticides, we oftentimes will see a higher concentration in children, young children, toddlers in particular, than we do in older children and adults. So part of it is because they eat, drink, and breathe faster on a pound by pound basis than older children and adults. Part of it is because they have these mouthing behaviors. In some cases, it's almost like putting stuff into their mouths is like a third hand. That's how they sort of experience the world. And that's not abnormal pica behavior I'm talking about. It's about a third of kids typically put non-food items into their mouth. It's very normal behavior. Unfortunately, if you live in a lead contaminated environment, you're going to ingest more lead. Um, there's also the blood-brain barrier is continuing to form, and lead may even disrupt that blood-brain barrier and make it more permeable for other toxins. And then there are instances we know where the enzymes that might help us break down things like organophosphate pesticides haven't fully matured. And so we're reliant on either the mothers or we just don't have those enzymes around. So there's a number of reasons that we are particularly concerned about the early developmental stages of children when it comes to toxic chemicals.
Yeah, and for example, in New Zealand, fluoride levels in young children, the under sevens, are higher than in adults. So we see that here too. So how do we start shifting to that black and white proof and take into account from sort of association to understanding that it's causation. Now, there's a paper by Bourguignon, 2018, and they stated that the demonstration of the favorable impact of the global protective measures on the level of the mother and offspring, studied by biomonitoring, together with the effects on a number of health indicators, will provide evidence of global causality. So, an intervention is substantiated by the numerous studies on the causal link between a given factor and a given adverse effect. So, we're starting, the idea is how do we say and help the public and help the politicians think about what causation might mean when we have a certain amount of evidence in the literature to sort of support a shift in how we regulate. Do you have better ideas than that or other thoughts that you could put towards this, please?
Yeah, I mean, I think the first thing we need to recognize is, and this is very much what we learned with the thalidomide crisis, is that we acknowledge that chemicals used as drugs have the potential to be beneficial, but they also have the potential to be toxic. And that was across the board. And so a very um, tightly regulated framework was put into place based on that assumption. Well, one of the things we need to acknowledge is that there really is no difference between exposing pregnant women or children for that matter to a chemical that's designed as a drug and a chemical that's designed to be used in the environment, in commerce, with one exception. And that exception is if it's being prescribed, you have a choice whether to take it or not. For the environmental chemical, it's really hard, if not impossible, to fully control it. And so that recognition, it seems to me, is the first step to recognize that chemicals have the potential to be toxic. And if we acknowledge that, then we need first to put in a much stronger regulatory framework in place rather than what we have been doing, and that is do some inadequate laboratory studies to gain approval or grandfather a chemical in, and then allow people to be exposed for 10, 20, 30 years, two, three generations, and expect people like me to come along and to be able to disentangle the effect of that chemical from all these other things going on in people's lives. I mean, I guess you could argue that we've been doing it. Why can't we keep doing it? Well, the problem is it means that there are millions or even billions of people who've been harmed before we acknowledge that this chemical or that chemical is toxic. It doesn't make a lot of sense. It's not the way I want to protect my family, my community, the public. It just makes no sense.
And part of this role is you can't just be one toxicologist doing this work. So the concept of multidisciplinary teams is really important. So you might have experts in gynecology and pediatrics, in endocrinology and toxicology and public health and epidemiology. You might have amazing stats nerds and machine learning dudes. And when you start pulling all of this together, you can get a really powerful picture of how change is happening. But right now, the regulatory agencies, they've got this barrier around that data, and they're not going into the literature and saying, well, Bruce, that evidence on fluoride and iodine is really powerful. We're going to take this into account. When I started researching glyphosate in 2012, I really thought that the agencies were doing they were surveying the scientific literature to come to a conclusion on the safety of a pesticide. I didn't realize that the gates are through the applicant, who is the corporate company, and they provide the foundational data. There is so much that we can do, but people need to understand the story. And, I'm going to quote you here because you've said personal action must be paired with public policy.
Yeah, that's right. I mean, there's a couple of things you brought up. One is too often we rely on industry data for the approval process. And we've seen numerous examples where that is inadequate, later shown to be flawed. The studies were too small. There's a second problem. In most cases, the regulatory agencies are not funding the studies that need to be done. So, as a scientist, I've got to figure out how to get the funding to ask the questions. So, I really have to be prepared. Take something like lead, and I'm not the first generation, I'm the second generation of scientists. So, Herb Needleman and many others spent 30 to 40 years of their careers studying lead. I've spent 30 years of my career studying lead. And at every level, I've got to figure out how to convince these funding agencies that the questions I have are important. Once we've gotten the funding, then I've got to spend 5 or more years of my life trying to answer these questions. Um, then, if you look at what's happened with lead and most of the other chemicals I'm aware of, it usually is dozens and dozens, if not hundreds of studies, all point in the same direction or the vast majority pointed in the same direction, that we then finally listen, right? So it's not like we could even call this a system. It's kind of this hodgepodge of things coming together, maybe, depending upon whether a scientist wants to be inconvenienced and spend their career studying this chemical or that chemical, whether there's funding available. It's not really a system.
No. And we know that undergrads wanting to go and study postgraduate work, that's kind of the one time they can be creative, but of course the funding will be limited. But once they move into the system, they've sort of got to follow what's already there. So you have path dependency based on the experts around you. So there's not a heck of a lot of Bruce Lanphears around researching lead and understanding these pesticides to sort of mean that you've got those those offices in those buildings all over the world. And that's why we simply don't have the lead expert in New Zealand. We don't have the glyphosate expert. We don't have the fluoride expert. We have one plastics expert, I think, but they're more social science researchers. So it's really, people need to just start asking questions. So Bruce, you're part of Little Things Matter. So I do urge people go and look at the videos. They're on YouTube. They're easy to find. You're the founder of Little Things Matter, and you've got a great Substack called Plagues, Pollution and Poverty, which I think is fantastic. It's great, and I'd like to finish with another quote of yours. You said virtually every standard for lead is based more on feasibility as opposed to the best science. When feasibility overrides science, who bears the cost and who benefits?
Well, industry, as long as they can continue to delay regulations, they benefit. They can continue to profit. And the public, children, pregnant women, the rest of us, we lose out.
So there's a lot of work to be done, and thank you for all the work you're doing.
Thank you.